Good afternoon and good morning, everyone, and good evening, everyone, from wherever you are joining us. Today, we have a special podcast with Professor Dan Polsky, who is the Bloomberg Distinguished Professor of Health Policy and Economics at the Johns Hopkins University. Thank you, Dan, for joining us today on this conversation. Essentially, the conversation would anchor around this emerging theme around how should countries plan for equitable distribution of the COVID-19 vaccine. So, Dan, if you could just share your thoughts, given the new report that you have been participating in for the National Academies of Medicine on equitable distribution of COVID-19 vaccine, that would be a great way to start the conversation. And then I can come in and ask you on your thoughts about how should developing economies like India and other contexts beyond the US should plan about the vaccine and its equitable distribution. Over to you, Dan.
Well, thank you. Just first, just thanks for inviting me to talk with you and share about our report and think about and reflect on how our lessons learned here from what we did in pretty much in the U.S. context can be extended and applied in the context of a country like India. So I was part of a committee, this wonderful committee that came together around this charge that was put together and sponsored by the National Institute of Health in the U.S. and the CDC. And this was all kind of came together in August and September as vaccines were entering clinical trials, and there was a sense that we really need to understand how because they're not all, we're not going to have two doses, I guess,
Right.
for every citizen on day one.
Right.
So how do we prioritize when there's limited vaccines, who should get it first? And so they brought together a team of interdisciplinary folks, ethicists, vaccine experts from various perspectives who've worked in public health for a long time. It seemed like everyone on the committee knew each other, except for me, they brought me on. I'm a health economist by training. My positions are both in the business school at Hopkins and in the School of Public Health. So kind of bridge two worlds and could hopefully translate the economic issues that are relevant for equitable allocation of vaccines for this committee of interdisciplinary experts. It's kind of where I fell into this. And the chairs were really just remarkable individuals. William Foge, who's the kind of a renowned scholar over generations and public health official who was really instrumental in eradicating smallpox, teamed up with Helene Gayle, who is the in charge of the Chicago Community Trust. And they really led this tremendous committee that I was a part of. But I'm just going to jump in and talk a little bit about our charge and how we approached it, what our principles were and how we made the decisions that we made, and kind of give you a quick rundown of the framework, and then just touch on a couple of key recommendations. So
Sure, Dan.
give me
Yeah.
about, I'm thinking about 10 minutes here
Sure.
to just run through some of this stuff. So the charge really was to develop a framework of equitable allocation of vaccines, but it really, part of this charge was also addressing how to actually, how these principles would actually be implemented. So it's one thing, just the framework included not only, here's our framework A, B, and C, but these are key elements and recommendations that are tied to making that that framework come to life. So that is just in a nutshell, what was our charge. It's important to say that we were an external body developing recommendations, and so we had no kind of force of implementation.
Right.
There are other committees and structures in the United States that are in charge of really kind of setting things forward, but it was important to get kind of bring together an independent panel to set forth a framework to help inform the decisions. And we really came from a perspective of what does the evidence say? And how do we translate that into a framework? Um, so I guess jumping into what we focused on is one, just ethical principles.
Mm-hmm.
All our decisions were based on maximum benefit. And I'll read you what we wrote: the obligation to protect and promote the public's health and its economic well-being in the short, and its socioeconomic well-being in the short and long term. So we spent a lot of time coming up with that phraseology, if
Mm-hmm.
you will. Um, but it's really focused on socioeconomic well-being and not just addressing short-term concerns, but thinking the long-term. Ethical principle number 2, equal concern. Consider and treat every person as having equal dignity, worth, and value. And the mitigation of health inequities. The obligation to explicitly address the higher burden of COVID-19 experienced by the populations affected most heavily, given their exposure and compounding health inequities. So that's really what drove us forward. We also had principles that were more procedural. All our decisions were based on concepts of fairness, transparency, and, as I mentioned earlier, being evidence-based in our choices. Our goal here is, in all our decisions, was reducing severe morbidity and mortality and the negative societal impact due to the transmission of SARS-CoV-2. So our criteria, what we ended up doing is created 4 allocation phases.
Okay.
So in the first phase, when there aren't that many vaccines, we actually broke it up to like, okay, kind of phase 1A and phase 1B. Like, this is early on, million, 2 million, up to like 10 million vaccines. Where do they go? First responders, high risk healthcare workers. This is like the kind of the immediate surge. Get it to the people that are in the line of fire, if you will. Phase 1B, so not just in the line of fire in that they're out there fighting the disease when there's a lot of morbidity and mortality. So the next kind of phase 1B are the people who are our greatest risk. So significant comorbid conditions, older individuals in congregate and overcrowded settings. And we define older as 65 and up. So that's phase 1, really addressing just kind of at-risk groups. Phase 2 are a number of at-risk groups because of how they place themselves in the functioning of society would be the best kind of way to bundle that phase 2. K through 12 teachers and school staff, childcare workers, critical workers in high-risk settings, people with moderate comorbid conditions, people in homeless shelters, group homes and staff, incarcerated, detained people on staff, all other older adults. So if you're 65 and older in the US, you fall into phase 2, chronic conditions, other at-risk groups, but also based on your employment, if you're really kind of part of the critical infrastructure in high-risk settings. Then phase 3, young adults, children, workers in industries important to the functioning of society. So, kind of the younger folks that have higher likelihood of spreading, making sure education goes unimpeded, and our society continues to function as kind of the promoting the well-being of everyone. And then phase 4 is all other individuals residing in the United States who are interested in receiving the vaccine for personal protection. So that is like where I fall, and I get phase 4. I think everyone in the committee realized that we're all pretty much in the last phase. So really through all this, we emphasized equity. So I'm going to stop there for a sec, see if you have any questions. We have a few recommendations that get to like how to kind of get unstuck in the United States to make sure these things actually come to be. But I'm going to pause if you have some questions.
Yeah, so I do have a few questions, and I'm glad that you started on the premise of ethics, because just today, as we talked, the ruling political party in India has a state election coming up, and it has premised the availability of vaccine as one of the election promises. So if you vote for us, you get the vaccine, and if you don't vote for us, you don't get the vaccine. Kind of a
Wow.
official statement has been made, and I saw on Twitter all day people are shouting hoarse on the ethics of making such a statement. So I'm glad you started there. And the second point that I'm noting from my friends in the Indian healthcare system is that there is a big concern about implementation. I mean, we can make recommendations about phase 1, 2, 3, 4. Obviously, those of us who work in health economics, we know that some of these vaccines may have adverse events. We know as the trials are going on, some data is emerging on adverse events happening with some of these trial patients. So how do we deal with that? I mean, India has a universal immunization program history here. The immunization technical support unit at the Ministry of Health supports this, and I'm sure there are American equivalents of that. So as you plan these phases, Dan, did the committee come up with thoughts on how to deal with these troubleshooting events? I mean, these adverse events. What happens? Do you stop vaccination if there is like a remote section of US or India which is getting it, but you suddenly see some evidence of some of these early vaccines not working, because these are also adult vaccines, and these are these mRNA vaccines which are probably going to come, and then there are these conversations on adenovirus immunity in Asian populations and stuff like that. So how does the national health policy authorities, US or India or anywhere, think about this in terms of dealing with adverse events as the phases are rolled out? Any thoughts there?
Um, yeah, so it really touches on all aspects of, kind of from ethics to phases to allocation to like communication. Uh, it's something that really entered every part of our discussion. It's such an important point. And, so number one is there's a lot of unknowns. So we did
Yeah.
some scenario. We have a number of a part of our report that really goes through, well, what if this, event occurred or that event occurred? And
Yeah.
we kind of come up with, here's our framework, but here's how you might need to adjust on the fly. And, I guess I'll speak personally rather than on the, kind of deliberations of the committee, but as an economist,
Yeah.
it was important for the early phases to have people who were at personal risk. So the risk benefit calculation in a time where there's still a lot of unknowns would favor putting them at the front of the line, in that we're not asking them to take a risk for everybody else. We're asking them to take a risk because they face a personal risk.
Yeah.
But ethically, they might there's going to be, it's not necessarily the case that the first vaccines are going to be the ones that work the best.
Yep. Yep.
And these are the ones we want to be protected the most.
Yes.
So it's a dilemma that doesn't
Dilemma.
really have any good answer. It's just to acknowledge that that's the case. And I think communicate, everything should be transparent. How do you communicate about the risks and benefits? Be very upfront about the rationale and the reasons for developing these phases. And we don't want to send the wrong messages, like you're at the front of the line because, there's a, like the early phases are not the guinea pigs, just to put it bluntly, like that is not the reason. The rationale is really tied to the risks that people face, and not that, and I think there's we spent a lot of time on communication. It's not my personal area, so I don't want to get into too many of the details there in the report. But just the fact that how do you communicate to all the different groups so that they are so everyone's kind of in alignment. And what was really important was that the voices of communication have to be like the people they're communicating to. So it has to really go down to the communities.
Yeah.
And that some, committee of the National Academies with all these people that sit in ivory towers coming together. Like if that's, if the communication comes down in that way, it's just bound to fail.
Mm-hmm.
So we set a general framework, and in the United States, the way the public health infrastructure is set up, it's really governed by the states
Mm-hmm.
and not a
Mm-hmm.
federal governance of public health. They just coordinate with the CDC, but their state offices are offices probably in every county, pretty much. So
Yeah.
it's really distributed to down to the local level. So it's the engagement of the existing infrastructure was very critical to our framework. We didn't want to create a new infrastructure.
Mm-hmm.
Fortunately, the infrastructure is a very local one where
Mm-hmm.
everyone's tied into their local communities. So I think that uh, the ability to make a left turn or right turn when needed, when things come up, to maintain the trust, um, is like that has to be executed on the ground.
Right. So just to summarize, I mean, for our listeners, you're saying that this dilemma that is there between those who most need it at a private level, but would also be potentially exposed to the least robust vaccines in phase one, needs to be solved by empathetic communication strategy involving communities, and where rationale is explained why this is being done, and the best that the state or the planner can do is actually being done, and the transparency of information, and you don't reinvent the wheel in terms of the vaccination and the public health infrastructure, but try to do as best as you can, letting it flow organically at the grassroots level is probably the message that I take from your intervention here for other countries as well. I mean, I understand the US has its own institutional context. My other question, Dan, if that's okay, and I'll let you flow into the recommendations thereafter, is on this issue of vaccine nationalism. So I'm seeing another interesting thing, and maybe it's less so of an issue in US, but definitely in India, I'm seeing these jostling happening between India and the Chinese vaccine makers or the Russian vaccine makers. And of course, you have the AstraZeneca and Serum Institute partnership going on. Conversations on, oh, if everybody should have the vaccine and it should be free, then you need to allocate so much more money. Where will the money come from? Should it be from an external financier outside of India, like the Gates Foundation, which has been historically involved with the immunization program in the country, et cetera, et cetera. So any thoughts on how vaccine nationalism might create distortions in these national plans there? And then, of course, you can go into your recommendations here.
Um, I think I can speak from the U.S. perspective.
Sure, sure.
I'm not as familiar with, it's just so much going on at the same time. But there was just a tremendous investment to get drugs to market, if you will.
Right, right.
Um, but really, the investment needed once the drug, presumably, knock on wood, these drugs will be approved and be allocated, and then there's a whole expense to get them into the arms of
Yeah,
millions of people.
yeah,
And so it what's the point of all the investment to create the vaccine if we don't spend the money to get them in the arms of everybody so they
absolutely.
do some good?
Yep.
That costs money too. And it it kind of remains to be seen if that money will be as robust and as
Mm.
easily allocated. It's there's a political economy to that.
Yes.
When there's a few intense interests tend to have their way in Washington D.C. or politically in general. It's not just our political system, but any political system. Then when
Yep.
it's totally distributed, with weaker interests are trying to have their way, it's less likely to happen. So it's not a surprise in any political system. I think you come up with that where the money shows up to give it to like these big, large players. But then how do you, leverage that for the benefit of society? I don't think we figured it out here, and
Mm.
imagine it's a challenge for all, across all nations.
Okay.
I don't know if
Okay.
that directly answers your
No, I
question. It's kind of a,
understand.
yeah.
I mean, you're saying that rationally speaking, having made these investments, you might as well use it for the social good and not let it become a deadweight loss in some sense, being caught up with these frictions from vaccine nationalism, etc. So I completely hear what you are saying.
Yeah, and
Um,
I'll show you in one of our recommendations how we kind of pose some of the cost considerations, downstream cost considerations. What I
okay,
might do here is share my screen for a little bit.
sure,
That's
sure. Yeah,
okay.
go ahead. Let's go ahead and do that.
Um,
I do want to take you up on the transparency point in the end, but yeah, let's go
great.
for the recommendation.
So here, this is a nice graphic in our report
Hmm.
that kind of summarizes the phases, which I was talking about
Right.
a few minutes ago. This jumpstart phase and the people at high risk, those kind of a step below in terms of risk, but also people engaged in high risk areas, children, young adults, those kind of that don't have no choice but to really be engaging and socially, not socially distancing, and then everyone else. So, but we also made a number of recommendations. First one was easy, like adopt our framework. Um, a number of recommendations were tied to coordination and costs, as we were just discussing. I'm sorry.
Hmm.
Um, and this one I had mentioned that we shouldn't build a new system to get this going. We should really leverage what
Yeah.
we have, because it's we need to get this deployed quickly. And I think we don't want the perfect to be the enemy of the good here.
Hmm.
Um, and then this one is provide administer COVID-19 vaccines with no out-of-pocket costs for those being vaccinated.
It's very interesting. Okay. Yeah.
Um, so the idea here, as I think you were alluding to earlier, is that there's a real externality. When you get vaccinated, you're not just getting vaccinated for you, but you're
Yourself. Yeah.
protecting those most vulnerable.
Yeah.
Um, so to ask the just their costs already to just getting out of your house, going down to the place where they're delivering it and getting vaccinated, but just like that you shouldn't have to pay for the administration as an individual. That has to come from some public fund, or else we perpetuate inequities.
Right.
Because those most likely to get it, if there's a charge, would be those that are most resourced, and that's really not why we created these vaccines. It's really to protect everyone. And so it's really important to make this recommendation. And as an economist, this was one of my favorite recommendations.
Hmm.
And I think it's tough, because I think it's not that the vaccination is free. I mean,
Yeah.
there was a lot of resources devoted to
Yeah.
developing the vaccine and then administering these vaccines, particularly with cold storage and,
Yep.
when do you purchase it? Where do you store it? I mean, there are a lot of costs involved with administration. Those
Yep.
costs should be paid, like the people that are engaged in this distribution need to be paid at a reasonable rate, so that we can have access around the entire country in areas that are, inaccessible, as well as those that are more easily accessed. Like, people still need to be paid. So the money has to come from somewhere.
Hmm. Hmm.
And different systems work differently. Here we have, those that are insured. There are ways to get zero cost sharing, and I could go into all the details, but there's so many holes in our system, and there's opportunities for each of these holes to, like, I thought it was going to be free, but I just got this bill for $2,000. Like, how do
Right.
we keep that from happening?
Right.
Um, so it's not an easy fix, and leveraging public health infrastructure for those that are uninsured and underinsured, for this place to go for free vaccines, and like a trusted location. So we want to, like, leverage existing infrastructure, including doctors' offices, but, like, let's use the firehouse too.
Hmm. Hmm.
And how do we best implement that, and fund it? Um, and so some of the argument is from a national economy level is, if we get everyone vaccinated sooner and get the economy back and going, like, this is the kind of thing that would pay for itself.
Yep.
But I haven't seen that modeling exactly, and I think that would be very
Mm-hmm.
helpful.
Mm-hmm.
So other recommendations included, we need to fund communication and community engagements. This is also something I touched on, that that the communication is critical, and it can't be done from the top down. So
Yeah.
it involves like a full like 360 strategy.
Right.
A lot of discussion around vaccine acceptance, addressing vaccine hesitancy.
Yeah.
So how do we promote? We need promotion of the vaccine, and it gets to, how we build that strategy appropriately with an understanding of where everybody's coming from. There's no good and bad here,
Yep.
um, and mistakes have been made by all parties in the past, and there are better ways going forward. And then our final recommendation, which was really important, is that if we're going to be if equity is at the top of our list,
Yeah.
that even though the charge was very U.S. focused, equity involves putting a portion aside for the global community. And so this recommendation gets into the details of how we do it. It's kind of U.S. centric, but that 10% of the supply that gets allocated to the U.S. for however that gets determined gets redistributed for global allocation. So those are the recommendations, and I'm going to stop the screen share and open it up to just chat a little bit more. Where's the end screen share?
So I'm very glad you talked about the global roles and responsibilities here. And earlier on, the essentially you are going to create a subsidy mechanism for underconsumption of vaccines. So when we teach externalities to students, we talk about vaccines being underconsumed, then that what is socially optimal. So the social planner tries to create subsidies, right? So I saw that you have these public vaccination clinics mentioned there and mechanisms. And I also loved your point about it should pay for itself. So if you can get the economy running and you can show some estimate of how much you are actually benefiting by getting the economy running with a mass vaccination program, maybe that should be able to justify today's subsidies that you are providing to individuals. So those are great points, Dan. So in general, let's forget about India, but in general, you have a flavor of the institutional vulnerabilities that exist in any non-US context, whether you go to sub-Saharan Africa or Latin America or Asia. All of these contexts are heterogeneous in their healthcare infrastructure deployment at one end, the income inequality / economic development issues at other end, and then there is politics. As you rightly said, there's political economy. At a big picture level, how would you say how do you see the next 12 months panning out for these institutionally fragile settings while they try to adopt vaccines? And what are the key things to look at um, um, as an alert point for society to quickly regroup themselves in case things go wrong, uh, and deal with a national vaccination strategy? That's one question. And the other question I had for you was um, this transparency issue, right? So if there are, God forbid, there should not be, but if there are bad situations where people are um, dying, let's say, like the Brazilian patient who had this situation in the control group, uh, how should society reboot itself and update its priors? We can't stop the vaccination program, I suppose, but I've been thinking about it myself that let's say it has to happen. And in case there are unforeseen events, how should societies think from a health policy perspective in rebooting itself and carrying on the job is there at hand? Or should we just assume that it would become like HIV in the long run? We'll get data. We have to just accept that COVID is staying with us and run with this show. So those are the two things. One is the institutional fragilities, and the other is this transparency issue. Any broad thoughts on how the next 12 months should be planned by economies on those two levers?
Well, one thing that I think is becoming clear is that vaccines aren't going to save us.
Mm, mm.
Um, we're in this for, probably, it's not going to end in 2021.
One.
the pandemic is here with us. Um, the social distancing and all these kind of non, pharmaceutical interventions
mm,
to prevent, spread, will be with us. Fear will be with us. Um, but what's new is, the vaccine is just one new element
mm,
in the
mm,
in the strategies. But also, we're going to get increasingly exhausted.
mm-hmm, mm-hmm.
Um, and also, there are going to be more therapeutics. We're
Yeah.
going to have more know-how to treat it. So hopefully, we've seen some of that. I don't know all the explanations, but that know-how is reducing the death rates.
Mm,
And so, it's still like far from flu, right? This is a really dangerous pandemic. The COVID virus is very, very dangerous and not to be taken lightly. And and the conversation about like, should we just accept this is like the new flu? It's just going to be a
mm-hmm.
more dangerous flu. That's become a really hot topic here. I don't have the
Yeah.
answer. I'm not an epidemiologist. It's not a place I'm going to weigh in on. Um, but clearly those conversations are entering. I think a lot of it is fatigue,
Mm-hmm,
right?
mm-hmm.
And this just and so this vaccine is going to be this new tool that I think for a long time the talking point was, oh, the vaccine will come and where everything will be okay.
Mm-hmm.
Everyone's looking for the magic bullet where
Mm-hmm.
everything's going to be okay. I think it's slowly dawning on people that the vaccine isn't the magic bullet.
Yeah.
And when you talk about adverse events and things are going to go wrong, like it's going to increasingly dawn on society that vaccine is not the magic bullet.
Yeah.
And in fact, it bears its own risks. I
Yeah.
don't think there's any way you could estimate those risks where they'd be worse than the pandemic itself.
Yeah.
But fear is a big thing. And it's this like immediate thing. Should I make the choice to get this shot? Is different than making a choice to like go to the grocery store
Yeah.
wearing
Yeah.
your mask to get some food. Um, and so that kind of immediacy of the decision will make even a very low risk event of an adverse event a very disruptive to the allocation. So I agree with you. Like, how do we handle that? I haven't seen enough conversation about that. I think it's a really important issue.
Mm-hmm.
And for me, it blends into this whole idea that we'll increasingly realize we are in this pandemic for a really long time.
Time.
And so I could see in 2021 the conversation shifting from vaccines to like, what's the next magic bullet? Maybe we just got to live with it.
Mm-hmm.
Um, and I think public health officials and I'd say economists too would love vaccination rates to get to the point of quote unquote herd immune. Get us to
Right.
the point of not being afraid of making transmission very unlikely. Um, but I mean, I think the truth is that there's just so many barriers to get us there quickly. And I think these fragile institutions that have kind of been evolving both in as a result of COVID-19 and preceding it will make that really difficult in a country like the United States. And I'm not going to speak for India, but I know we're not the only country that has kind of increasingly fragile institutions trying to execute on strategy.
Right. And Dan, one last point. Do you really think there is herd immunity for COVID-19? I just want, I mean, since you're in Hopkins and you are interacting with doctors and molecular biologists and epidemiologists, an interdisciplinary cohort of colleagues, uh, and we hear about reinfections happening and long haulers and antibodies not being there for more than 3 to 4 months. And at the other end, we know the costs that this pandemic is incurring on society from non-COVID care and broader negative externalities on the economy. But yet, I mean, if we, I mean, suppose there is no herd immunity, or suppose there is herd immunity, how do we it's festival season in India. Okay, so my motivation for asking you is that question is, it's very, very difficult as a policymaker to think about how much to open up the gates in festival season in India and not to let open the gates. I can completely empathize with the situation in Delhi, how to manage this. So Any reactions to that, Dan? And I've heard this herd immunity debate also in the US. So uh, broadly, how do we think about it?
Yeah, so I don't want to speak too far out of my expertise, but so it's not my area, but I have conversations with the epidemiologist experts here at Hopkins, and I think one thing that drives them crazy is everyone misinterprets, excuse me, the word herd immunity and what it is and what it means. It really is it's a term that's applied to vaccines.
Hmm.
Get to the point at which you can't vaccinate everyone
Mm-hmm.
uh, for a lot of conditions or people that are very vulnerable that can't get the vaccine. But if you get enough other people to get it, you protect the vulnerable that can't get it.
Yeah.
But it's really a term I think that's used to make transmission unlikely. You don't have to get everyone vaccinated. So the person who
Right.
comes with some counterindication doesn't have to get vaccinated if rates are high enough. And it doesn't apply to like getting everyone the disease
Right.
so that uh, like it stops spreading. There might be a term for that, but it's not herd immunity from the perspective of the people
Yeah.
that I talk to. All right.
Yeah.
But I think there's a confusion there. It's used, I think, outside of the context of how an epidemiologist would use it. And so the idea that instead of giving a vaccine where you can get immunity without being at risk, general risk of getting the disease you're getting vaccinated for, the idea is, well, let's just give everyone the disease. That's some other concept.
Mm-hmm. Mm-hmm.
um, and I know some people are advocating for that, at least among people who are at low risk of dying. And that's a way to protect the vulnerable. So getting immunity through being exposed to the disease and being at risk of getting it, I guess, is some version of herd immunity. And that's what you're talking about. And I guess my view on this, and it's not a very informed view, is it's more of a kind of a numbers, econ, geeky kind of thing, is, it's a law of large numbers here, right? So of course there are exceptions, and the vaccine might only have 50% efficacy. But as you increase the rate of people who are
Right.
immune, even if there's some exceptions, as a society, it's going to spread less frequently.
Yeah.
Like maybe if I get the vaccine, it doesn't mean I'm going to go around like,
Crazy.
licking people. I'm going to still wear my mask, and I'm still at risk. I'm just at a
Right.
lower personal risk. Um, but if enough people do that, then, transmission, it'll just slow down, right? And it'll
Right.
keep going. There's probably no perfect herd immunity, but you could imagine it asymptoting.
Yeah.
And I think, but it's nonlinear, right? So you got to get quite a ways before it really starts grabbing hold and reducing transmission rates. And it's that nonlinearity that I really am afraid of for the festival season. I
Mm.
think we find a lot of ways.
Yeah. Thanksgiving is coming there as well, right?
Yeah, it's going
Christmas.
to
Yeah.
be, but putting yourself in a nonlinear situation is
Mm.
probably what really needs to be avoided, which is, all right, it's one thing to be around 10 people where maybe one have it. But if I'm around 1,000 people and 100 have it, it doesn't, it's a nonlinear increase of my own risk, but also of just having, even if it wasn't nonlinear in terms of my own risk, it's nonlinear for the community. If you're
Community.
around.
Yeah. Yeah.
And so, ultimately, if we want to avoid shutting down the economy and just avoiding any risk, we should at least be avoiding these nonlinear events.
Right.
That's
Right.
and that's going to be for a long time.
Yeah. Then any concluding thoughts? And you have been steering the business of health initiative also at Hopkins, right? Apart from this program, and I know that some very fascinating cohort of scholars around you are working with you and everyone else at Hopkins to understand global health and public health economics better. Having done this over the last 6 months, any broad reactions uh, that we as scholars, as students of health economics, should be aware of as a senior scholar?
Yeah, I mean, one of the, I don't know if silver lining is, painting it too optimistically, but this emergency, this global pandemic has brought people together, academics together in new ways. And I've always, in my whole career, I'm an interdisciplinary scholar, barely a health economist, very interdisciplinary in my approach. And I think I've always held on to this belief, more of a farsighted, like the way to address complex problems is to bring people together who approach problems from different perspectives.
Mm-hmm.
And if you keep, hammering with that nail with that same hammer, it's going to, you're not going to address problems in new ways. The creativity, the ingenuity, the innovation happens from kind of mixing things up in new ways. And you really see that through this pandemic. But you also see how stuck we are in the old ways,
Mm-hmm.
and how that really perpetuates challenges, both in terms of communication, but also in terms of finding new ways to address problems. I think early on in the pandemic, the epidemiologists and economists were kind of being pitched as the people who are pro-lockdown and the people who are like pro killing people to get the economy going. And I don't think any epidemiologist or economist really
Not
adhered to
true,
that,
and
but
yeah.
it just kind of felt like it was going against each other. But if I think the disciplines deserve some responsibility for that, that dialogue, which was
Mm-hmm.
not productive, because we tend to speak from what we know and speak
Mm-hmm.
with the language that we know, and it can be misinterpreted. And so the more we can connect across disciplines, and it's what we're trying to do with the Business of Health Initiative, and just the term of it, business and
Of
health,
health,
like,
yeah.
and in a place that is dominated by public health, the idea of kind of business and health, and the business of health is like, what do we mean by that? I think there's a lot of curiosity, but also just really kind of pushing and tweaking to think a little bit in new ways. And that's what we're trying to do. And I think there's a real opportunity because there's such a need to address this crisis.
Thank you so much, Dan. I think this was a great conversation. I know you have a very busy schedule, not just as a distinguished professor in Hopkins, but several other administrative responsibilities. But we really appreciate your time and thoughts for us, because I think we are all at a critical juncture of society, like you rightly said, where, as they say, we are all in this together and we have to think about it creatively. And hopefully, we'll all be safe and we'll learn a lot from this. I mean, I was talking to someone else earlier. Hopefully, when there's a SARS-CoV-3, we'll not repeat some of the mistakes that we have done this time around.
Yeah.
So, yeah. Thank you so much, Dan. Yeah.
Well, thanks for inviting me. It's really a pleasure to chat with you in this format, and it's always a pleasure to chat with you in the other formats as well. But I very much appreciate it.
Thank you, Dan. Please stay safe and take good care. We would love to host you
Okay.
sometime in campus.
Oh,
Bye-bye.
thank you. Take care. Bye-bye.